All right, let's get started. Good morning, everyone. Thank you for joining us for the Healthy Transitions Colorado November 2015 webinar. My name is Kristen Paulson. I'm with the Center for Improving Value in Healthcare, and I'm very happy to be here with you today as we talk about the whys and hows of medication safety. So Healthy Transitions Colorado is run by our operating partners, the Colorado Healthcare Association, Telegen, the Colorado Hospital Association, the Colorado Medical Society, the Colorado Rural Health Center, the Colorado Behavioral Healthcare Council, and Health Teamworks, and we're managed by the Center for Improving Value in Healthcare. Healthy Transitions Colorado is a collaborative effort focused on aligning and accelerating existing efforts to improve transitions of care for all Coloradans. Our guiding principle is that by breaking down the silos of healthcare, we can foster true community care coordination across facilities, specialties, and practices. HTC coordinates the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. If you haven't already done so, we'd like to invite you to become one of our community members, our community partners, and take the pledge to improve patient care transitions. To take that pledge and learn more about HTC and what we do, please visit our website at www.healthytransitionscolorado.org. So a couple of housekeeping things before we get started today. The phone lines have been muted, and they will remain so throughout the webinar. We're going to use the chat feature available in the lower left-hand corner of your screen to field questions and allow you to make comments on the discussion. Questions posed to the presenter will be answered during the question and answer session after the presentation. This webinar is being recorded and will be posted to the HTC site so you can access this information again at any time without cost. I would also like to quickly mention our upcoming final Learning Series Symposium, Fostering Patient and Family Engagement, on January 15th, where we're going to be focusing on collaborating with patients, families, and caregivers in all settings and across the full continuum of care. Registration is now open at our website, www.healthytransitionscolorado.org. I'd now like to introduce our guest speaker, Katie Brown. Katie is a clinical pharmacy specialist for Telegen, one of the Quality Innovation Network and Quality Improvement Organizations for CMS. She is the task lead on a multi-state effort on medication safety and adverse drug event prevention. Katie is a proactive, passionate, hardworking doctor of pharmacy licensed in Iowa and Kansas with over 12 years of experience in pharmacy management, patient care, and policy. Katie, go ahead.
Thank you, Kristen. Can you hear me okay?
Yep, we sure can.
Okay, great. And thank you for that nice introduction. As she mentioned, we are the QIO for the states of Iowa, Colorado, and Illinois. And our QIO activities include direct technical assistance to providers to improve the outcomes of and demonstrate the value of healthcare services for Medicare beneficiaries. Next slide, please. Our improvement activities support the National Quality Strategy, the Partnership for Patients, the Million Hearts Initiative, and other national and local work. Next slide, please. Our shared goals among the QIOs and QINs foster community coalitions of patients, caregivers, and clinical teams to improve the quality of patients' transition between the healthcare settings to reduce avoidable hospital readmissions, as well as adverse drug events in order to keep beneficiaries healthy and in their homes. Next slide, please. So today, this discussion will hopefully drive a collaborative approach for you to decreasing adverse drug events and to also give you some ideas and tools to incorporate medication safety into your workspace. Maybe some tools you're already familiar with and hopefully some new ones that you could use. We also need to look beyond our own walls and realizing that any one of us, any one entity can't do this alone. Next slide, please. By using a community approach, we can use the data to analyze root causes, to drive change not only in your facility but your community, and also to engage all healthcare settings to improve outcomes. And we'll talk a little bit more about the tools and those root causes a little bit later in the presentation. Next slide, please. Improving medication safety also plays a key role in productivity, quality of life, and overall healthcare costs, which is why it's very important that we talk about this issue today. Next slide, please. Not only is quality improvement important to elevate your patient's care, but because payment models are shifting the risk away from payers and onto the providers, it's forcing us to focus on patient outcomes as drivers of payment and revenue. Next slide, please. The push for medication safety that we're going to talk about today in particular is guided by the Health and Human Services National Action Plan for Adverse Drug Event Prevention, and this was released by them in the summer of 2014. Next slide, please. We know that adverse drug events cost the system at least $3.5 billion per year. And as you can see, that there are over 1.5 million adverse drug events each year. Next slide, please. We also know that adverse drug events are largely preventable, and therefore they're a high priority target in our healthcare continuum, and that's why this National Action Plan came about. There's studies that show anywhere from 20 to 40% of hospital readmissions had to do with an adverse drug event, and there's likewise studies that show that over 50% of those are likely preventable. And when you equate that to the billions of dollars, that you can see how that really adds up quickly. Next slide, please. One CMS goal is to improve medication safety and to reduce the incidence of adverse drug events by 35%. So it's not only tied to a reduction in healthcare spending on readmissions and emergency department visits, but also to improve medication reconciliation, patient education, and provider communication. Next slide, please. The National Action Plan guides you to improve safer use of these three classes of medication: anticoagulants, the diabetic agents, and the opioids. These three classes were deemed the highest risk and most common for serious and life-threatening adverse events. And these are the adverse drug events that I mentioned earlier that account for billions of dollars in healthcare expenditures each year. Next slide, please. To standardize the use of the term ADE, or adverse drug event, and potential ADE, we will use the Institute of Medicine definitions for our purposes today. So an ADE, as referred to, will be injury resulting from a medical intervention related to a drug, and as I mentioned, most are often preventable. And a PADE, or potential or preventable ADE, is a medication error that could potentially lead to an ADE but is stopped before harm can occur. All right, next slide, please. So we have to have data to impact change on a larger scale, and the data and the tools that we'll talk about today are more about the why of the medication safety. And participation in any medication safety effort or quality improvement effort requires your timely attention to and collection of data. So we'll talk about some available resources, and if you're interested in participating with Telegen for quality improvement support and resources, please feel free to contact me. My email address will be at the end of the presentation. Next slide, please. So CMS has proposed revisions recently to the IMPACT Act, and this includes having a medication reconciliation process with the goal of improving patient safety by enhancing medication management, and this will affect hospitals and calls. So let's talk about some of the tools available for your use in both these inpatient hospital and outpatient settings. The first is this first set of tools is relative to medication reconciliation. The breakdown of communications in our transitions continuum is leading to increases in prescription errors, adverse events, and the subsequent hospitalizations or primary care visits. Each outpatient adverse drug event is estimated to cost over $2,000, and I've seen different studies, and unanimously the average is over $2,000. Some are upwards of $4,000. And then when you cross into the inpatient space, you're talking, from $4,000 to $12,000 because of the hospital stay. The Marquee Toolkit is a Society of Hospital Medicine resource, and it has a great section to help promote the necessity for MedRec improvement for your facility, and it also has a return on investment calculator for the inpatient setting. So if you're still at the why phase, why this is important phase, you might check that out because there really are some great resources to use from a business perspective as well as the implementation phase. The Match Toolkit is an AHRQ resource. It has a great section to elevate your work plan and improve the MedRec processes. Both of these are available online at no charge to access, and you can also download them to implement in your practice. I would say if you are choosing to implement those, be sure that you're also measuring what you're doing and documenting the processes so you can really track your improvement. And then the last link is here at Telligent, I created a medication reconciliation assessment tool, which anyone is welcome to use by following that link. And what you would do is assess your admissions and discharges or transfers as you receive a patient to care for. And in turn, I help you monitor your processes and the progress towards your goal of improved communication with patient transfers about MedRec. Okay, next slide, please. The next set of tools to discuss involves patient engagement. The PAM tool, or Patient Activation Measure tool, is a product of Insignia Health, and it's from research done at the University of Oregon. It's a licensed questionnaire tool to gauge patient activation about their healthcare and medication. This product does require licensing for use, and that is available for discussion through Telligent. If you're interested in learning more about that, their website is listed there for you, and they have some great resources to learn about their tool. The next tool involving patient or beneficiary engagement that I found is the Adherence Estimator. Now, this is a product of Merck, the pharmaceutical company. The Adherence Estimator is based on extensive research regarding the 3 C's, the patient's care, cost, and concern. So it measures and predicts adherence for patients receiving new medication. This gives you an opportunity to react to a situation with appropriate counseling and monitoring. I think we often have our own preconceived ideas of adherence and why or why not patients are adherent. And they really have done a good job at researching the available information and really have narrowed it down to the care, cost, and concern, as I mentioned. This resource is also free and available to use on the internet. There's also a widget that you can embed in your electronic system. And if you would like to use that tool, please feel free. But if you would also like my support in measuring your success of adherence changes, please let me know. And then the third tool that I want to talk about for engaging beneficiaries is local to you in Colorado, and that's called the Patient Passport. And this is a product of Sharing the Care Initiative and the University Health System up in Fort Collins. And the Patient Passport is like a pocket portfolio that the patient carries around with them with a booklet of information in it. So it contains their pertinent health information that is populated or filled out by the patient or caregiver, and then it's carried with the patient to every appointment, every transition of care, etc. It's really cool because it has not only like their medication record, their appointment schedule, but it also addresses things like what does the patient like, what are their preferences. So there's also a section for the legal information, which is necessary, but I think often we overlook really the patient's wishes. What do they respond well to? How would they not prefer to be cared for? So if you're interested in learning more about the Patient Passport, you could reach out to the Sharing the Care group. Next slide, please. So I want to talk a little bit about home health quality tools as it relates to medication safety, and this is a link to a home health quality improvement tool. So home health agencies' quality ratings are definitely affected by drug education, and I've had questions about how is that calculated and what can we do about it. This is a snippet of some of the measures that they use to assign a rating, and then the link actually is a tool that uses some of the requirements. So the tool itself assesses the exact metrics, the numerator and the denominator, that are used to calculate your rating. It's open to any home health agency, no charge. You don't have to log in. You just go and use it. And it's to assess your records once per calendar month. So right now, for example, you could assess your home care portfolio from October and then go online. There's only 12 questions on this tool, and then you don't get immediate feedback online. What happens is I assemble the information, and then I assist you with your quality improvement based on the metrics that you've entered. And then we're able to quantify and track improvement, as well as make adequate, specific interventions for you to help you improve that rating. So if you're a home health agency interested in improving your quality rating on drug education, please feel free to use this link, and then I would be in touch. Next slide, please. So there's other quality improvement opportunities for you, and I want to talk briefly about electronic exchange of information. So interestingly enough, currently pharmacy is not included in this process, but there's work underway to change that. Pharmacy integration into electronic information exchanges will not only enhance information sharing on behalf of the patient, but also empower the patient to have complete, current, and timely medication records. So as it stands, there's a state health information exchange network where physician-level providers are able to share patient records and care documents, and pharmacy records are not included in that process. So we're stuck between the previous slides of engaging beneficiaries and then this slide of encouraging patients to own their medication record. So I definitely think there is work to be done nationwide from the perspective of making sure that all healthcare professionals in the continuum have the same accurate medication list. I've heard people say, that when there's discussions about medication lists, well, who's it right? Is it the doctors? Is it the pharmacy? Is it the specialty doctor, et cetera? And what I've heard more than once is the list that's accurate is the one the patient has in front of them that they say they're on. So we have some work to do to make sure that what the patient is actually taking is, 1, correct in the record, 2, shared across the spectrum, and 3, has input from their pharmacist. So we are doing some work on that, and if you're interested in that, I'd be glad to follow up on that as well. Next slide, please. So let's talk a little bit about data. Data and these tools that I've talked to you about are very useful because data and collecting data with these tools is a critical component to quality improvement being successful. So as the QIO, we use Medicare claims data to assess not only outcomes but populations. And this is an example of using claims data to assess the impact of medication safety. So this map shows Medicare beneficiaries at high risk of an adverse drug event that were prescribed an opioid. In Intelligent, we use this type of data in conjunction with the quality improvement tool data to help guide your efforts in improving medication safety and quality improvement. Next slide, please. My apologies for the bottom of it being a little light, but this is another example of data that has been collected and analyzed. And so overall, your initial response would be that Colorado has a lower risk population for adverse drug events related to the high-risk category than the national rate. But the fact of the matter is, when you look at side-by-side data with readmissions data, you'll see that adverse drug events are still costing your state billions of dollars each year. Next slide, please. So you want to do a little bit of quality improvement, work on some medication safety, but where do you begin? So what I would recommend is that you create a work group within your organization to identify high-risk beneficiaries and then focus your project on a specific pool of beneficiaries. It often seems really big and overwhelming if you try to tackle, let's say, MedRec. It can be really big and really scary and really unclear. But once you start to narrow down your population of focus, you can really see some change start to happen. So small bits at a time, get a work group together to start thinking about this information from what you learned today. Next slide, please. So I'd like to shift away from medication safety in particular and talk a little bit about quality improvement in general, because these principles are true whether you decide to work on medication safety or just communication or readmissions or staff stability. Whatever your charge is, these next few slides will help you in that. So let's start with leadership. Maybe you're a leader in your organization, and so we want to make sure that your leadership is reflective of your mission. And as a leader, how do you lead your team in quality improvement efforts? And how do you support failure as a learning opportunity rather than being punitive? You may find as you get your team together that they're scared to try new things, but failure is just another way to say a learning opportunity. So we want to be sure that that's a culture of quality improvement and not a punitive culture, so that people aren't scared of change, as typically we can be. Next slide, please. So CMS is pushing us out of our comfort zone. And down at the bottom, we're safe here for a while, though they're hitting the hospitals pretty hard with penalties. But who's next? Nursing homes, home health, maybe even pharmacies. So here we are down at the bottom in our little bubble doing just fine. Thank you very much. Leave me alone. Maybe you're not in a horrible place. Maybe you have a few issues that you're working on. And then all of a sudden your bubble has been popped. Maybe now you're a one-star nursing home because of antipsychotic rates when they refigured the calculation. Or maybe you're receiving payment penalties for hospital readmissions. And those penalties are coming, and for many of us, sooner rather than later, as you well know. So here's the good news from this today, that everyone's going to go through the same thing, and that we'll all figure it out together. There's a lot of help out there. There's tools that I've shared, a lot of other tools, ideas, and also other people. Feel free to reach out to your peers, this organization, anybody in the healthcare spectrum. We're all going through the same thing together, and we just want to be sure that we're sharing our ideas and resources. And so once we get out of our comfort zone, that's when the magic will start, and you'll start to see change. Next slide, please. So we did the best we could with what we knew, and when we knew better, we did better. So, for example, years ago, we thought we could not live without physical restraints in nursing homes, right? But today we know better, and many facilities are restraint-free. So just like that, with data, over time, we know better. And so today we've talked about quality and safety, and hoping that what you know tomorrow, because of your efforts to collect data, will be better than what you knew today. Next slide, please. One quality improvement tool, if you will, is writing a SMART goal. And writing a SMART goal is often useful as you begin to think about what to do next. So if you leave here today, you say, what now? Your goal should be SMART. First of all, your goal should be specific. Who is going to do it? What are you going to do? Where is it going to take place? So when I said earlier to create a committee to start working on these efforts to narrow down your patient population, who is that? Don't say a nurse. Say Jill. And what are we going to do? Don't say we're going to meet. Say we're going to meet every Friday 8 a.m. for 10 minutes in the break room. That's very specific. Your SMART goal also needs to be measurable. What measurement will you use? What's the current measure, and how do you want the measure to increase or decrease? So if you're working on fall rate, what are you using to measure that? Maybe you're using your MDS. And how much do you want that to decrease by? It also has to be attainable. And so what will you base that on? Are you looking at the national rate? Are you looking at your neighbor's rate? Think about, is it too high? Is it too low? How do you know if your goal is too high or unrealistic? Is a 0% fall rate realistic? I don't know, maybe, but that's something to think about. What are you basing your goal on, and make sure that it's attainable? You could always write a new goal later after you've attained your first goal. Relevant. So how will your goal affect your facility? How will it affect your ratings, your payments? And then think about what else it might affect. And your SMART goals also need to be time-bound. So what is your target for reaching the goal? Maybe you're going to decrease your fall rate by 10% by May of 2016. It has to be time-bound. What will you measure between now and the end of your time frame, and how often will you measure it? You're not going to get anywhere meeting once a month or once a quarter and measuring something once in a while. You need to meet every week, measure it often. Change can happen quickly, even with a small amount of measurement. So one SMART goal, I'll use an example about medication safety. If you are going to write one, it might sound something like this. To decrease anticoagulant adverse drug event-related readmissions from a certain XYZ skilled nursing facility to our, insert your name here, hospital, by 2% by February 1st, 2016. So when you leave and start thinking about quality improvements in medication safety, think about your goal being SMART. Next slide, please. Okay, the 5 whys of root cause analysis. So using a root cause analysis tool will help you turn your I think into an I know. So I think the problem is versus I know the problem is. And you want your I think to really be an I know. And to find out, we use the 5 whys. There's no magic formula here. You identify the problem, being very specific in using data. It can't be an I think. So saying that the nurse calls in sick all the time, that's an I think, not an I know. Saying the nurse called in sick 3 times in 30 days, that's an I know. So be sure you're identifying the problem specifically and you're using data to come to that conclusion. And then you're going to ask yourself why 5 times. And you must be able to control or fix the reason. And it's really hard to do in healthcare because you can't use medical diagnosis. You can't say, if your problem is a high number of hypoglycemic adverse drug event-related readmissions, and then you say why, you can't say because we have a large population of diabetic patients. You have to stay away from medical diagnosis, and you also can't control or fix the reason. So keep those in mind. It has to be an I know, and you have to be able to fix the reason. So I want to walk through an example right quick. So my question is going to be, why do we have anticoagulant-related ADE readmissions? Okay, so first let's talk about the problem. We have a lot of anticoagulant-related readmissions. We can't use that because that's an I think. So try again, what's the problem? Then we come up with, in the last 3 months, we have had 20 anticoagulant-related readmissions. Okay, yes, that's an I know. That's a real number, real information. Now, why did this happen? And Susie says, the patients didn't follow the instructions. Well, no, this is an I think, and you also can't control the reason, so you have to try again. Why did this happen? And then Susie says, well, 18 of the 20 patients had a high INR at readmission. Yes, that's an I know. We can use that. Okay, now ask yourself why again. Why did this happen? And she says, well, they probably doubled up the doses when they went to the facility. No, we can't use that because that's an I think. So try again. Why did this happen? And then she says, well, 10 of the 18 patients did not have a repeat INR as was ordered. Okay, yes, we can use that. That's an I know. It contains real information. And then you do it again. So why did this happen? And she says, well, they're too busy. Well, okay, maybe that's the case, but we can't control that reason. So try again. Why did this happen? And she says, the staff is not trained on the INR protocol. Okay, yes, that's an I know, and you can control the situation. And then one last one. Okay, why did this happen? And she says, well, there's a new lead nurse. Well, no, you can't control the reason. You likely aren't going to go back and hire someone different. And so you try again. Why did this happen? And she says, oh, okay, the INR protocol was not included in the nurse training procedures. So ding, 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 yes, you can control that. So we went from, we have a lot of anticoagulant-related readmissions, which is an uncontrollable I think, to an INR protocol that needs updated in the nurse training procedures. We have an I know and something you can control. So hopefully you can use this this tool, the 5 whys, and apply that to any situation, whether it be at work or at home. It really works well if you really follow the rules. No speculation, and you must be able to control or fix the reason, or you have to answer it again. Next slide, please. And then to tie it all together, for rapid cycle change, we use the PDSA, or Plan, Do, Study, Act. And so you're going to write your plan using the SMART goal. And then you're going to plan your path, you're going to do it, you're going to study and measure it, and then you're going to act. And this goes around and around and around until the process has successfully been accomplished. And by that, I mean when you get to the act phase, after you've studied it, you have 3 courses of action that you can choose to tie it all together. The 3 A's. You can abandon your idea. So maybe when you fixed the nursing training protocol manual, it was horrible. Nobody understood what it meant. They said, no, we were trained, that wasn't it. Whatever the case may be, you can choose to abandon it and start over. In that case, you would do your root cause analysis again and come up with a new plan. The next choice is adapt. The second A is adapt. So you can say, well, it sort of worked, but we still didn't get quite trained as well as we could have, and some of the INRs were missed. So try it again. Write your plan again with your adaptation. Do it, study it, and then act again. And your third choice on act is adopt. So the first time you rewrote the training manual, everything went fabulously from then on out, and you choose to adopt it. From then, you can move on to a different issue. So plan, do, study, act, and when you come to act, you can abandon, adapt, or adopt. And like the other tool, the root cause analysis and the SMART goals, this concept can be used in quality improvement, whether you're at home, interacting with your family. I have a team member who uses this at home. It's really funny to hear her stories about that. Save those for another day. But you can use this at home. You can use it for medication safety. You can use it to reduce falls, readmissions, communication in your community, etc. It's a really good concept. If you've never done it, I encourage you to try it on something that may seem very trivial to you. And it's really cool to see the processes or the progress that you can make. And it's also not uncommon to do at least three PDSAs before you get it right. Okay, next slide, please. So hopefully after today, you can turn some of your I thinks into I knows and make strides for meaningful improvement in patient safety. When you leave here today, try to answer some of these questions and then answer what is your next step. Next slide, please. These are some of the references. Next slide. And then I would like to offer time for questions now, and then we can go to the next slide and have my email address up there if anyone has questions or would like support on any of the things that were mentioned. So Kristen, if you wouldn't mind going to one more slide, and then I'm all set.
Thank you so much for the presentation, Katie. This is a lot of really great actionable information. So let's see what kind of questions we've got. We have one from Joy Mathis. My company is Medication Solutions. We provide an in-home medication dispensing machine. Hold on just a second here. This product helps with medication adherence and gives patients and caregivers and family members and physicians peace of mind, and it's web-based and secure. Have you ever heard of such a device?
I have heard of like devices that help with safe medication use in home, and I think there's a great opportunity there to help with patient safety. There certainly is a need, so thank you for sharing that.
And as folks enter their other questions in the chat box, I've got a couple here that I collected during the presentation. I'm going to go back a little bit in your presentation. I was really surprised to hear that pharmacy is excluded from electronic health information. Do you know what was behind that decision? Is that a local Colorado-specific issue or a national issue?
Nationwide, there's a lack of pharmacist inclusion in health information exchange. And when I said that, I was referring strictly to the state health information exchange portal, not EMRs. So if you're a pharmacist in a health system, you certainly have access to that EMR. But when it comes to interstate connectivity with other healthcare professionals, pharmacies across the board has been excluded. The best answer I can tell you is that because at this point pharmacists are not recognized as providers in the eyes of CMS. So when business entities are writing rules and plans for healthcare correspondence, pharmacy is overlooked because they're not in the list of nationally recognized providers.
That seems to be a major gap that we can start looking at changing. That's concerning.
Yes, definitely. And there are efforts nationwide and locally to change provider status for pharmacists. In fact, some states at a state level recognize pharmacists as providers in the Medicaid space so that pharmacists can be recognized and included for billable services. But from a national level, that legislation has not passed yet.
Interesting. So another question, do you have any information about what progress is being made? Are we seeing a positive trend in reducing ADAs nationwide? What are you seeing going on?
Yeah, there's a lot of conversation between the QIOs in this space, and there certainly have been thousands of adverse drug events that have been prevented. But because this is such a new initiative, so to speak, we really, if we're talking we're going from A to Z, we're maybe at B or C. We have a long ways to go. And I think the fact that this has become recognized as a national initiative on so many fronts, several national organizations are looking at medication safety as well as different government-funded projects. So I think we're making progress in the awareness phase more so than impacting outcomes, but it's certainly coming.
Okay. And speaking of that, that was another question I had. You said that we're at B and A through Z. Do you have an idea of what C, D, and E are going to look like? What are those next going to look like for providers across various facilities?
That's a great question. I think moving to C, D, and E will have a lot to do with payment reform. And by that, for example, I mentioned, the IMPACT Act and really more restrictions on safe medication use, payment reform for nursing homes, hospitals, and in the pharmacy space, payment reform, just to keep their doors open. The quality ratings at this point are tied to the payer. So again, there's a gap in what these professionals are able to do versus what they're recognized for. So I think payment reform, I think that's a big task, but it needs to be sooner than later.
Yeah, I agree. Do you see any major, what do you see as the major opportunities for advancing medication safety? Are there any what are the big low-hanging fruit that you'd like to be aiming for?
Well, the first low-hanging fruit would be to start paying attention to the medication and safe use in your facility, regardless of where you practice. And I would look at those high-risk populations, the anticoagulant use, the diabetic agents, and the opioids. We know that those alone are costing us billions of dollars, and that's only 3 classes of medication. We didn't even talk about the other 100. So I think as far as low-hanging fruit goes, I really would strive to focus on your highest risk population, and start thinking about what you can do to improve safety for them.
Great. Well, if there are no other questions from any of our participants, thank you very much again for this presentation, Katie. This was fantastic. And thank you everyone online for joining us. This is the 5th webinar in our learning series, which is designed to complement the symposia. Please remember to take a moment and register to join us on January 15th for the final symposia in the Cultivating a Network of Care series, where we're going to start looking at engaging patients and families collaboratively in the care model. So registration is available through the HTC website and under the Take Action tab on the right-hand side of the screen. I hope this has been a valuable use of your time. Please stay tuned for information about our December webinar and more information about the event in January. The webinar has been recorded, and we will be posting it on the Healthy Transitions website in the next couple of days. Thank you, everyone. Have a great day.